So welcome everyone to our Elder Abuse Prevention Ontario's webinar today called Closing the Gap, Promoting Health and Dignity for Black Older Adults. I'm so pleased today to be in the acquaintance of three well-astounded physicians who are going to share their information and knowledge with us and the work that they've been doing to help advocate for the rights and for healthcare in our province within Ontario and even beyond borders. So we're going to be talking a little bit around some of the experiences that older adults have faced in healthcare, how we can, some of the barriers of access to supports due to systemic racism and inadequate services, what systems need to be changed, the conversations and actions that should take place to advocate towards more of a healthy and safer communities for everyone. I will do our introductions in a moment of all of our speakers, but before we begin, I would like to give our land acknowledgement. So we acknowledge that we gather on the traditional territory of a number of First Nations and acknowledge their stewardship and land throughout the ages. We seek a new relationship with the original peoples of the land, one that is based in honor and deep respect. Before we begin, I do have a few small housekeeping items to let people know. As you know, we do have that chat box, so you can put your questions, put your comments in there. Everyone will be muted during the presentation. Our speakers will be visible throughout the presentation, so you'll be able to see them. I will go off screen when the presentation starts. And we are recording the session, so if you miss something or you want to go back and see the recording or the PowerPoint, it will be posted on our website later today or tomorrow for your viewing. As I mentioned, you can put comments in the chat box. We always like to, if you have something to add or contribute or have a link or resources that would be helpful for not only our speakers, but also for other participants. We'd be more than happy to have you share that. And if you have a specific question for any of the speakers that we have today, please post that in the question box so we don't miss your question at the end. Sometimes when we get going on the chat box, a question could be put in there, and sometimes we do miss that. So I might remind you if you accidentally put it there, but we do encourage you to ask questions, and we'll do that at the very end. Just the other housekeeping item is that, like many organizations, we do like to hear your feedback on today's session and options for future ideas for webinars. So if you're handy and you have your phone, you can do a QR scan. We'll be posting the QR code at the end. There'll be also a pop-up button, a link at the survey at the end, and we do a follow-up email that provides the link to the recording as well as the survey after the webinar as well. So lots of options too. It would take like 1 minute. There's 7 questions. It doesn't take very long. And just lastly, before I introduce our speakers, we do respect your privacy and confidentiality during the webinars. This is a public forum. So if you have a specific issue or situation that you want to talk further to us about, we've been more than happy to do that offline. You can email us, and our contact information is at the end. And we'd be more than happy to answer that. So just try to keep anything maybe case related to very generic because it is, as I say, it is a public forum. For those who are just joining us for the first time, just to give you a background, just a few slides about who we are as an organization. Elder Abuse Prevention Ontario our vision is really to create a province and society where all seniors are treated with respect and dignity and have a voice. So often we see the visibility of older adults in our society. So we're really trying to change that for, advocating for their rights and respect. And we work in collaboration with many organizations, community partners to assist in that advocacy and service coordination to respond to the needs of older adults in our communities. We can't do this alone. It does require us to work in partnership, and I think our colleagues will speak to that during our presentation today. We do implement Ontario's strategy to combat elder abuse and have been doing so since 2003 when the government implemented the strategy. We are funded for the strategy from the Ministry for Seniors and Accessibility. We are a nonprofit organization, but we've been given that mandate to implement the strategy, and we are accountable to them in terms of the work that we're doing to support seniors across Ontario. So that strategy has three main pillars, as I've kind of alluded to. The main ones, main pillars of that strategy are public awareness, training, and that coordination of services. So you'll see us very, very active on our social media. We do education to seniors. Everything's virtual. Unfortunately, we haven't gone back to out in the community very much because of COVID, but hopefully that will change in the future. And we do lots of training to frontline providers, whether that's in healthcare organizations, community services, justice sector, victim support, businesses, retirement homes, you name it, we're kind of out there providing the training and education. And as I say, we do work with our community partners because we can't, as most people know, when you come across a situation of abuse, it does require a multidisciplinary approach, working with our partners. So trying to increase our capacity at the local level to respond to abuse, because it does require that team approach to support someone in that wraparound services, given the dynamics of this situation. So now it gives me great pleasure to introduce one of our first speakers, Dr. Mireille Norris. She is an internist and geriatrician at Sunnybrook Health Sciences Center in Toronto. She's also the lead physician for quality improvement and the post-grad education for the Division of Geriatrics at Sunnybrook. Her role includes assistant professor of medicine at U of T and the education director at Sunnybrook Hospital training program, which she created and implemented in 2005. And she's also been very, very active in her passion for inclusion and equity and diversity. And that's reflected in her participation at Sunnybrook as the president of the Anti-Racist Task Force and other equity initiatives at the hospital and also at the University of Toronto, and also the Dementia School of Medicine, as well as her commitment to serve the Black community at the Taboo during the COVID vaccination clinics, as well as the Centre Francophone de Toronto. So you can see that she's also got many, many other credentials behind her. So we do welcome you, Dr. Norris, to our session today. And along with Dr. Norris is Dr. Jenny Huang, and she is a geriatrician and clinical associate at St. Michael's Hospital. She's a lead for improvement on social prescribing to combat loneliness in older adults during her subsequent fellowship. She's currently completing her PhD in clinical epidemiology and healthcare research at the Institute of Health Policy Management Evaluation at the University of Toronto. So she's very active. She's been also involved in some long-term care adverse cognitive outcomes, looking at that kind of research and databases. And I know she's working extremely hard to finish that PhD. And Dr. Norris and Dr. Jenny Huang work very closely together, from what I've learned just recently. And lastly, we're joined by Dr. Mireille DenBow-Burke, and she is a family physician who holds a master's in public health with specialization in gerontology from the University of West Indies, Mona, Jamaica. She hails from the beautiful island of St. Lucia, where she's actually joining us from today. She's very passionate about educating and improving the quality of life for seniors. And to that end, and she's the co-founder of the Senior Sessions, and she'll be talking about that today, a multimedia information-based initiative aimed at increasing awareness and discussing issues relevant to the geriatric population. And her aspiration is to be a national and international policy advisor on public health provisions for older adults. So thank you all for joining us today. I know we are in for a wealth of information and knowledge that you're going to share with us on so many important issues. So I do look forward to your presentation today. And I'm going to stop my screen share and turn that over to Dr. Jenny Huang to start the presentation.
Thank you. Thank you. I'm so keen to share my passion today. And the title of my talk is Caring for Black Seniors. Next slide. There's no conflict of interest. Next slide. So here are my learning objective: to describe some ethno-cultural consideration in providing care to Black older adults, explore systemic discrimination and barriers to culturally appropriate healthcare, and then identify resources to provide culturally appropriate care, including steps to enact cultural practices. Next slide. Okay, first objective. So, as we can see, Black Canadians today have diverse background and experience. I'm an immigrant from the Caribbean, born in Haiti. We have immigrants from Africa. Some came here as refugees. Some are descendants of early settlers brought to Canada by slavery or escaping slavery from the United States. Some are second or third generation immigrants. So we're a very diverse community within the Black community. Next slide. So one thing that does bound many Black Canadians is a history of trauma. And the trauma is historical, stemming from the legacy of colonialism. Some of it is institutional, as rules in schools, in hospital, in law, in police have perpetuated trauma in our community. Some is intergenerational. I was born in Haiti. My parents left during the Duvalier regime. I did not experience that regime, but the legacy of that is passed to me, to my parents. Some of it is personal lived experience, as racism is ongoing, in this country and worldwide. So therefore, it's important that we apply a patient-centered lens, and we realize that not all Black older adults come with similar needs. And someone can experience privilege, someone like me experiences privilege, and at the same time, racism. We've seen how Masai Ujiri, leader of the Raptors, while they're celebrating a win, is also subjected to racism on the same event. So we want to be person-centered and avoid generalization. Next slide. So we're going to try to briefly talk about anti-Black racism, critical race theory, which had some controversies in certain spheres, and discuss some organization tools such as anti-bias testing. And so anti-Black racism was actually coined by a Toronto professor, Dr. Akua Benjamin, who was a social work professor. And it seeks to highlight the unique nature of systemic racism on Black Canadians and the history as well as experience of slavery and colonization of people of African descent in Canada. Now, I come from Haiti, and we've got a thing called colorism, such that within the Black community, different shades of brown and Black are subjected to different amount of discrimination, such that the discrimination can even occur within our own, as there is an internalization of racism. Next slide. And so because slavery was an institution, it devalorized, being Black. And so even if it's no longer an institution, while it does still persevere in certain parts of the world, there's a negative stereotype, and it is linked to skin color. Next slide. Now, what is critical race theory? Many people, have challenges understanding that it's an academic framework that's centered on the idea that racism is systemic. It is in the laws and the rules in which we operate. And it's not just demonstrated by individuals with prejudice, such that racial inequity is woven into our legal system. That's how we see disproportionate representation of Black people in the criminal justice system and different sentencing of Black people compared to other ethnicities for similar crimes. And this has negatively affected people of color in their school, lower school achievement, high rate of dropout, doctor's office, different outcome for similar medical condition. And I already alluded to the impact from the criminal justice system. Next slide. So, as someone who's a doctor, a lot of the racism has been woven in a medical practice under a pretense of scientific legitimacy. So race is not a biological construct, but sometimes it is presented as if it is. So eugenics is the scientifically inaccurate theory that humans can be improved through selective breeding of population. So the implementation of such practice has caused widespread harm, particularly to populations that are being marginalized. And here we're focusing on Black people, but Jewish people have been also targeted with the same eugenic practice, and we just have to go back to the Second World War and the Nazi regime. So just to put it into this understanding that eugenics is a scientifically erroneous and immoral theory of racial improvement and planned breeding. And we have to be, as healthcare providers, scientists, we have to be aware that racial racism is an ideology and that it appropriates the methodology and legitimacy of science to argue for the superiority of white Europeans and the inferiority of non-white people. So we have to be critical of that. So anti-bias testing is used in organization as a way to help bring awareness to what is sometimes unconscious. And so in the anti-bias testing, pictures are sent, such as here, we have a Black and a white person, and we have to respond rapidly, and the rate of response and the quality of response can help bring up what might have been otherwise unconscious. And with this increased awareness, we hope to change attitude and practice. So the next objective, let's explore systemic discrimination and barriers to culturally appropriate healthcare. Next slide. So racism is a public health threat. It was really heightened how COVID epidemic raised that we brought awareness to reality. So racism can cause frequent stress on the body, trigger stress coping behaviors that often lead to disease, and also there's trauma associated with the experience of racism. So experiencing systemic discrimination and microaggression are social stressors, and they increase the risk of negative physical and mental health, including anxiety, depression, suicide, suicidal thoughts, cardiovascular disease, breast cancer, high blood pressure, premature mortality. And I'm going to expand a little on that later. You can see on the next slide how there was this different prevalence rate of infection of COVID on the red, where there's a higher proportion of Black Torontonian. And in that catchment also, we realized that there was a lesser adoption of vaccination practice, but there was also less access to vaccines as there were fewer pharmacy, fewer family doctor's office. So that's when we see that it's systemic. And whereas on the right side, where the more affluent neighborhood, smaller prevalence of Black people, there was a lower rate of infection. And then between these two groups, there's also a different, one was able to socially isolate on the blue group, work online, higher level of education, whereas within the racialized group, a higher prevalence were frontline workers, multi-individual, many individuals living in small space, more difficult to socially isolate. So next slide. So we're going to briefly go over how these different conditions, dementia, depression, pain, end-of-life care, are lived by Black people who are older. Next slide. So when it comes to dementia, compared to whites, the rate of institutionalization is lower. There's a higher rate of reliance on family and on caregivers, which is can also be associated with more caregiver stress. So some of the themes that were identified to explain that difference is that culturally, there are often families who are identified as Black want to focus on the individual that they love that is losing their memory, as opposed to the diagnosis of dementia, which removes a person from their personhood. Dementia means without mind, and it is really a term that devalues the person. There's also a feeling and experience that many services geared to Black seniors who have dementia are felt to be disrespectful. Caregivers of Black seniors who suffer from dementia feel a sense of responsibility towards the older person, and the importance of religion is really affects how care of older people who are Black and have dementia is lived. Next slide. When it comes to depression, we see that African American have multiple comorbidity and functional impairment. This is data from United States, and associated with that higher rate of depression. However, those seniors who have depression and are Black are less likely to have access to psychiatrists. And even if they score positive for depression on the CESD score, they're less likely than white people to be recognized as being depressed by their primary care doctor, half the rate, according to this paper. And they're less likely to receive active treatment. And if they are treated, they're less likely to stay on the medication that is offered. They often have less access to psychotherapy, and they're more likely to rely on informal support, such as religion, for counsel. So the course of untreated depression is poor. There's a high level of chronicity in major depressive disorder, and that increases mortality, suicide, coronary disease, physical health problems, functional disability. And so we talk about the neurohumoral immunological aspect of depression, and that increases the risk for cardiovascular disease. So when it comes to pain, there's also a disparity, and very sadly, from American literature, you know, in the 1800s, doctors who were owner of slaves, you know, perpetrated in the literature that Black people had a different threshold for pain, and these prejudice towards the management of pain of Black seniors. And there's also the issue of mistrust by certain healthcare workers who have had a perception that Black people who complain of pain are seeking drugs to relieve pain. And there's a lot of literature around sickle cell anemia patients who come with sickle cell disease in pain who are not getting their pain addressed. Culture plays a role in the experience of pain, how pain is communicated, whom to report pain, the type of pain that should be reported. So, you know, here, this is a paper from the United States, and one of the quotes was that the problem of disparities in pain is worsened by the current and past policies within the United States public healthcare system. So again, we're going back to this, you know, legacy of legal structures that categorize people and affect how resource and treatment is delivered. Next. So, you know, I like this tool, which is called a 4-stepped approach to creating cultural congruency. And so, you know, different people of different race and different people within the Black community will experience pain differently. Some people believe in being stoic in front of pain, others very expressive in front of pain. So, you know, we want to try to appreciate, acknowledge the experience of the person in front of us, see how we can enter negotiation to maintain our professional standards as a healthcare provider, but also integrating cultural values of our patients. That might include, you know, resources that are ethnocentric, but not necessarily within our tools that we're used to prescribe as healthcare provider, how can we accommodate and align the values of our patients with, our standard? And, when we can, or if we cannot, can we explain and engage in a conversation so that as we practice, we can build cultural congruency? It's really how can we meet our patients halfway at least, as opposed to just dismissing their needs. Next slide. And so when it comes to end of life, unfortunately, we see a higher use of critical care at the end of life with Black patients compared to whites, and a lesser use of palliative care, which leads to a lot of suffering at the end of life. And it's often rooted in mistrust. Next slide. Here's my mother, who was critically ill. She basically had a witness arrest in a critical care bed, and her surgeon saved her life. But we were very fortunate for having exceptional care. But there are issues of mistrust between healthcare workers, language barriers, lack of familiarity with the healthcare services. Low health literacy can create more difficulty with building trust. Next slide. So I'm gonna wrap up with just a few culturally appropriate resources. So, how do we build cultural competency? So it's a process. It's a process, and it is, some people say it's in a not achievable process, and perhaps, as opposed to us trying to build competency, what is the most important thing is that the people that we care for feel culturally safe. But cultural competence is a language that is used in healthcare, and it's believed to be at the core of high quality patient-centered care, and it directly impacts how care is delivered and received. And if we can achieve cultural competence, we can alleviate poor patient outcome, reduce health disparities. And as we build this competency, we also increase our job satisfaction, and it can help increase staff retention. Next slide. So some of the ways this can be achieved is through delivering care within a system, and in the system, we can offer interpretive services, we can recruit more minority staff, we can increase cultural awareness, knowledge. At Sunnybrook, for example, we attended the SANIAS training to improve care of our Indigenous partners. There are similar courses that are available to improve care of Black seniors. We can coordinate with traditional healers. And I once had a colleague ask me, I have a patient who practices voodoo. How do I accommodate that? Well, it is a religion. So it's about having the conversation, using community health workers that are culturally specific or focused, have the awareness, trying to link our patient with services that are more aligned with their values, and incorporate culture-specific attributes, values into our health promotion tools. Next slide. So it's a process. We develop awareness, we build knowledge. As we practice, we develop more skills. And do we seek cultural encounters that can help us feel more competent. Next slide. And so this is just more in words, but it's the same thing as the diagram. It's really developing a process where we keep on being more skilled, improve knowledge, seek encounters, and develop desire to be more competent. Next slide. And this is my mom. It's less than 1 minute. She'll share her experience with the healthcare system.
Last January, my mother fell ill and she almost lost consciousness. in the kitchen, so I had to call the ambulance. And they came and they gave us really, really good service. They asked us all the questions that they needed to ask, and she didn't look ill. She had regained consciousness.
No pain?
Yeah, she had regained consciousness when she came back, and I helped answer a lot of the questions that they asked. And one of them spoke French, so that helped her a lot because her English is a bit limited. And she didn't look ill when they came, so it was really good that they insisted that she go in the ambulance.
And they were nice.
And they were very
They
nice.
convinced me that will be okay, everything will pass okay with me.
Yeah.
And it was at the hospital, they take care well.
Yeah, so it can be done. And we were so blessed that my mom was cared so well, and we're forever grateful.
Last January, my
Next slide. Sorry, I didn't want to repeat it. Next slide. So in summary, they were awesome. They included my sister. It happened that the ambulance worker could speak French. My mother actually was in shock. That's why she fainted, and she had a transfusion. And although my mom was resistant to get into the ambulance, she had vitals that indicated she needed attention. And by allowing my sister to join in the ambulance, that also helped my mom accept the care. Next slide. Yeah, so take home message, be aware of your own unconscious bias. The truth is everyone has them. So it's really having that willingness to overcome. Keep humble, we're all learning. Try to adhere to continuous learning to improve cultural competence, develop skills in building trust, relationship with Black seniors and their family. And we covered where that could apply. And during the pandemic, the loneliness was really highlighted. And I'll pass the mic now to Dr. Huang, who will share with you her experience of screening for loneliness and offering options to counter loneliness. Thank you.
Thank you so much for the introduction, Dr. Norris. So my name is Jenny, and I'm a geriatrician at St. Michael's Hospital. Today, I would really like to take the time to share an initiative that I led, supervised by Dr. Norris as a trainee in geriatric medicine at the University of Toronto. So I would like to use this project to share my experience in patients with loneliness. And we know that this is an issue that would be only exacerbated, especially given the systemic issues related to racism. So I do not have any conflicts of interest to declare. To first understand the issue, it is really crucial to differentiate social isolation from loneliness. So social isolation is defined by the lack of a social network or support, whereas loneliness is defined by when we perceive ourselves as lonely. For example, a person can feel lonely even though they have family or friends around. But being lonely does not indicate that we're necessarily socially isolated, but certainly being socially isolated can contribute to loneliness. So loneliness matters a lot because it affects 40% of adults over the age of 60. This number is certainly higher since the pandemic. And despite this prevalence, loneliness is an under-recognized issue. And loneliness is dangerous because it's associated with higher risk of psychiatric illnesses, frailty, lower cognitive function, functional status, and higher mortality. Loneliness is a complex issue to identify and to treat, as it is associated with social isolation and stigma. So thankfully, there is evidence that social prescriptions such as animal therapy, meditation, and virtual care are effective to reduce loneliness. Previously, we had other trainees who recognized the importance of screening for loneliness and was able to bring this rate of screening in older adults who were seen in the clinics from 12.5% to 84.6%. However, despite the high success rate with regards to screening, there were only 50% of participants who were identified as lonely actually got a social intervention, such as a referral to a social worker or being involved in a community support group. So to walk through our project, to walk you through it, we started this project in September 2020. We were 7 geriatric medicine resident physicians who created this project in our weekly clinic where we had the most autonomy as trainees. our goal was to increase the number of social prescriptions in patients that screen as lonely. We then offer them our standardized social prescription that I'm going to show you a little bit later to patients for them to accept or decline. In both cases, we would follow up in clinic again in 3 to 6 months these patients. So to start, a patient would show up to the geriatric medicine clinic, and then we would ask them the 3 questions that I'll show you later to see if they're lonely or not. And then we would see if these patients would be appropriate for a social prescription. For example, if a patient had severe cognitive impairment, causing them not being able to follow some commands, or having follow exercise that would help them with loneliness, then unfortunately we wouldn't be able to offer them this social prescription. But otherwise, the social prescription would be offered, and we would follow them again in 3 to 6 months. In this Ishikawa diagram, we identify factors that contributed to the suboptimal screening of loneliness and treating of loneliness. So we conducted interviews with stakeholders such as social workers, geriatricians, and patients. And from the patient's perspective, we see that their comorbidities, their frailty, the number of medical appointments that were just taking too much time, and the perceived stigma associated with loneliness, the linguistic barrier, the limited access to local services were the major barriers. At a system level, the limited funds attributed to programs to help combat loneliness, the lockdown measures were really the main challenges. So with all these factors in mind, we introduced a standardized social prescription that was readily available to physicians to address loneliness. Our objective, again, was to give as many social prescriptions as possible to patients who identified as lonely. And here we put a number of 70% as a target for patients who screen positive for loneliness by May 1st, 2021. So this was the scale that we used to identify loneliness. It is great because it's evidence-based. And it takes around 1 minute to administer. It's really shown to have also a high inter-rater reliability. So that means that if I rate it and Dr. Norris rate it, we would have the same results most of the time. And so here, I just wanted to take a minute to walk you through the social prescription. So we created and incorporated the social prescription containing local services that align with the public health directives. As you can see, we made sure that the telephone or video conference services were available if patients had significant concerns about infectious risks. More importantly, the social prescription was accompanied by a referral to a social worker or the appropriate mental health services, depending on the patient's needs. So I'm happy also to distribute this PDF that we made, and perhaps we even update it with newer services. So just showing you some preliminary results that we had. There were 169 medical visits in the geriatric medicine residence clinic between November 15 and May 12, 2021. The prevalence of loneliness was high, comparable to what's in the in the literature at 32%. And 65% of lonely patients received a standardized social prescription. We wanted to increase that rate for sure, because we also realized that at first our rate of screening was not maintained at 63% versus the 84.6% from last year. So based on these results, we realized that clinicians had some difficulty screening and treating for loneliness. We went through 4 PDSC cycles where we wanted to make things better. So we did a few things. We incorporated loneliness screening in our comprehensive geriatric assessment. So that very long evaluations that geriatricians administer to their patients, we add that as a portion of the template. So resident physicians wouldn't forget to ask these questions. We also reduced the questions a little bit from the 3 questions to even a simpler 1 question, are you lonely? Because we realized that the questions were a little bit redundant and may trigger a very long conversation that maybe the patients were not ready to share at that appointment. We also provided a physical reminder in the clinics to remind the clinicians to ask the question. And lastly, we also asked help from our administrative agents when they're doing their pre-appointment intake assessment to ask for loneliness and to provide that prescription right away if the patients were identified as lonely. So, just to come back here. So this was what we had before. And then by adding these, we can see that this here, is the screening and this is the prescribing. So as time went on and as we implemented the 4 cycles, we really got a better rate. And here we actually reached the rate of 100% when it comes to having patients who identify lonely getting the social prescription in the end. So this project did have a few challenges. First, with the redeployment, as you can see with the timeline, there was a, kind of in the middle of a third pandemic wave. So there was redeployment of the medical personnel and a lot of hesitation from the patients to even come to clinic or, being assessed by a geriatrician. We lost around 2 months of intervention time. But more than ever, there were multiple competing medical issues. So, geriatricians, we'd like to do as much primary prevention as possible. So a lot of clinicians were actually catching up on these tasks, such as, making sure that patients were getting vaccinated, having their, critical medical issues addressed. But I think what's really exciting about this project is, despite the difficult time, we were able to provide a lot of social prescription, and by the end, 100% of lonely patients received a social prescription. Obviously, the standardized prescription being how it is, it cannot be appropriate for all patients. So patients who had significant dementia or cognitive impairment, language discordance, or hearing impairment couldn't go through a lot of the services providing on this social prescription. Furthermore, we were unable to control external resources, such as some volunteer groups that had limited capacity, that had to close down during the pandemic themselves as well. And so even though we can provide the social prescription, we still don't know what's the effectiveness of social prescriptions or social interventions, because that was not the end goal of our project. We know that these social interventions are effective from the literature, and we just wanted to make sure to prescribe or provide the social prescription to as many patients who need them as possible. So in conclusion, loneliness was definitely a prevalent problem during the COVID-19 pandemic. Creating a standardized social prescription definitely increased the intervention rate, made the task for physicians to prescribe that much easier. And this automatic screening and prescribing by a constant personnel, which in our case was the admin agent, really created more sustainability. And obviously, here we're in this Black older adults focused talk, but race and gender were not the main priorities with this project. And a barrier, of the standardized prescription was that it wasn't curated specifically for Black or other racialized groups of older adults. So future work is definitely needed for a more diverse population group with, better catered services, also for gender, for age, and other frailty groups stratification. And I think what's really also good about this project is it made me realize how we also have to take into account some services. And I'm excited to present the next speaker, Dr. DenBow-Burke, who's going to talk to us about some of the resources that may be better curated to Black older adults.
Just before we begin, Dr. Kwan, do you want to just go back, maybe just even ask people? We forgot about the poll questions, but that's okay. But it always is good before we get to the next step, just as we've gone through just both presentations, just even ask about the isolation questions. So I'm going to post them, and then maybe we can just do the first two and see what the responses are. So the first question I'm just going to launch that we had was just asking people if you've ever talked to your physician about social isolation or just isolation itself. And I know there's been a lot of work being done on social prescribing. So I'm really glad that you mentioned that, because we're also going to be doing, I think in the future, a webinar around this issue. And I don't think people sort of think, am I supposed to talk to my physician about that kind of thing? Because it's really, is it not medical, right? So it'd be interesting just to see what people say. So most people are saying no, because when people ask you what your problem is, you kind of allude to maybe a depression. You don't think of loneliness as an issue. So just kind of gives us an idea of what people are saying. So most people are saying no. I'm just going to end the poll and share the results. So as I say, most people are saying no, but so this may be, hopefully after the session, people will start maybe asking or doing that as well. The other question I just want to post is access to resources. Just another question for everybody, just to say, do you feel like you have access to resources if you did feel lonely within your community, which will bring us to our next presentation. in terms of talking about resources and supports. Because oftentimes we don't think about what resources are available until we actually, in a crisis and that we need them. So some people are saying, just so far, we got about 65% of people are slowly kind of responding. Let's give it a couple seconds. I know that people are asking for some of those tools around the list. So if you send me that PDF, I can post that for people if they want. I know it's GTA focused, but that's okay. A lot of, it gives us motivation to, when we do talk to our healthcare providers, to maybe develop something like this for them to healthcare providers to give out to older adult clients. So the results saying that 66% do say that they do have access to resources. So and some don't. So it just kind of gives us the idea that, we need to do some more work in regards to the work that we're doing. So sorry to interrupt.
Thank you so much for that. And that was actually a really reassuring response to the second question. So I'll let Dr. DenBow-Burke take away.
Good afternoon, everyone. I am Dr. Rachel DenBow-Burke. I'm the co-founder of Senior Sessions Healthcare. I'm just going to ask Rayanne to launch a poll, please.
Helps if I unmute myself. Just another poll question, as you see here, would you be interested in receiving a social intervention through social media? I think that's really important because we now with COVID, we are shifting everything is online, zoomed out every day at the end of my day. But it's also a way of connecting with people, right? I think people are becoming more adapt to it and becoming a little bit more tech savvy, whether you can participate like I think you're going to share, Dr. DenBow, about that, how we can get connected. So people are answering. So I'm just going to, there's a few more people. Oh, almost like half and half, which is interesting. So I'm just going to end the poll. So it's 50-50, which is really interesting, isn't it? So this is yeah. So I'm just going to stop screen share and I'll let you carry on and we'll do the last poll at the very end. Thanks.
So I'm a family physician and I also hold a master's in public health with gerontology specialization. So Senior Sessions Healthcare is basically a media and communication based initiative which is focused on older adults, and it aims to enhance the quality of life of seniors and their care, and also to educate them. My husband and I founded this social media platform in 2020 in the height of the COVID-19 pandemic. After speaking to our, families who were elders and also, persons around us in the GTA and Ontario who seemed very socially isolated and lonely. And we developed this platform to help share knowledge and resources and to speak about certain issues that were affecting seniors, just generally, and also at that time, of this COVID-19 pandemic. Next slide. So we focused on a lot of topics, which I will just briefly mention. And then you could always, at the end, join the group and follow for more videos and focused topics and discussions. So one of the topics some of the topics I could say, or some of the discussion points that we looked at was ageism, where you have negative attitudes and stereotypes against people who age. We looked at elder abuse and the perpetrators of elder abuse and some of the ways that we could help alleviate this, or some of the ways that the abusers and also the family members could actually seek help if needed. Next slide. We also looked at sexual health in aging, which is a very taboo topic for seniors. They don't really like to discuss sex in aging, and we spoke about ways that they could address some of the issues as they age, as well as being comfortable in even speaking about their sexual health as they age. We looked at principles of money management, where seniors gave advice to the young population of how they should have saved for retirement, for healthcare, and so on and so forth, and help to earn capital, protect their finances, and different advice, categories that they wish they had known in previous years, or would have been passed down to them from the other generation. Also, we looked at diet in aging, and I made a small video of a smoothie with different, fruits and oats that would have many proteins, antioxidants, and vitamins in. Next slide. Also, I invited my husband on, who is a cardiac anesthesiologist and intensivist, where we spoke about post-op delirium, basically where elderly patients are going in for surgeries, and most times they have inattention, hyperactivity, cognitive changes, and sometimes, their family and caregivers don't really know how to handle these issues, right? And we also looked at the incidence of dementia, right? And we looked at statistics as well around that. Next slide. So some of the topics that will be coming soon would be caregiver burden, senior-friendly homes, mobility challenges, interviews with older adults. These are some of the discussion topics that we would like to discuss. And this is the page, the senior sessions page. So this is the senior sessions Facebook page that you could access. You could join the group, as well as sign up and subscribe on our YouTube channel. So this is just an external resource that is available that we should all, try to tap in and market and give each other and share with our seniors so that they could access. Thank you. Any questions?
We just have that one polling question, just asking people, because there has been just a comment around how many people do have access to Facebook or use Facebook, because somebody was asking a question, which we'll get to in a second, just in regards to that. That's okay. So so far, we're getting some responses. Almost there. We got about 26. Wait a couple seconds more. So majority of people online. It's gonna end the poll. So the majority of the people indicate that they do have access to it, but not everybody online is an older adult, but it's a lot of maybe service providers or family members. So sometimes we do see some differences in terms of age and access to those supports as well. So just interesting just to hear from people. So thank you. Just so before we get going, I would like to pose that one question that people had, which was just leading into that polling question that you posed, was that are you thinking of any other kind of alternatives besides social media, Dr. DenBow, to have these programs? Because as I say, not everybody has access to that, and there's such valuable information that you are sharing in the community. Are you able to?
Sorry, Rihanna, I wasn't able to hear.
Oh, I'm sorry. Well, I'm just wondering if you are thinking of expanding the program that you provide online to maybe in person or through other venues.
Oh, yes, definitely. I mean, with the COVID pandemic, we started off as a virtual platform, but we do in time there is scope to bring it to more of a community outreach program, as well, like within Ontario, within other provinces. I mean, it all depends on, you know, the manpower to do so, of course, and even have interactive discussions with seniors, in small groups, of course, within the community, as well as virtual, where they actually share their experiences, they share some of the issues affecting them. And I think that in itself would make it more interactive and pull more seniors to look at discussions where they're the ones actually, you know, driving things. Yes.
Great, thank you. I know there was a couple questions that were posted in the Q&A that Dr. Norris responded to, but some people may not have been watching the Q&A. So I'm just going to repeat them, and maybe if you want to expand on them, Dr. Norris. So one of the, which I had actually on my list as well, this question around doctors' awareness of social prescribing, and Dr. Kwan, like how many doctors are aware of this, or has there been further outreach or education to doctors about social prescribing, and what's the uptake on it?
So thank you. Actually, just before the pandemic, there were now increased awareness of loneliness as a public health, matter. There were even an old initiative in England of addressing loneliness through social prescription at a national level. And then the pandemic hits, and then the awareness of loneliness, its prevalence, its risk in terms of other health outcome was raised, particularly among primary care physicians. And research on it and the prescription of social program is now slowly being pushed to doctors. And certainly in England, they can, if you have a prescription from your doctor to go to the museum, you can go for free. So this is an idea that is taking hold, but we are at the same time having a healthcare crisis where we don't have enough doctors to deal with infection in the emergency room. So I think if the population feels more empowered to communicate this, certainly the medical community is more aware that it is something that they can help alleviate.
Mm.
And I think it's a really good question, because so talking from the field experience, when we're asking these questions of loneliness to our patients, they were actually quite surprised. And they, some of them even didn't feel necessarily comfortable talking to their physicians about it, because they felt, obviously, if you ever went through a comprehensive geriatric assessment, you know how long it is. And they felt that, why does it have to be addressed with the geriatrician? So I think there's a little bit of doubt also about, maybe how important it is. And I think hopefully my first slide showing how loneliness is a huge risk factor to mortality, to frailty, to cognitive dysfunction, should be convincing enough to both the public and the physicians about the importance of addressing that. And maybe that could also change a little bit for the future. And we could follow, actually, like Dr. Norris said, the UK's footsteps with regards to, just getting the awareness out there, and also considering that actually a cost-effective intervention as for the social prescription.
Great, thank you. What was I just going to say? How often do doctors work or with social workers? I know sometimes family health teams have a social worker on board within their team, but is that a commonality that with social prescribing that they kind of work in tandem or make a referral to a social worker?
Certainly, as a yes, so definitely. So sometimes by making referral to the LIN, we can send a social worker, we can make linkages to the Alzheimer's Society if it's in the context of dementia, or the Arthritis Society. So we're getting more adept at doing that, especially with technology. It makes it sometimes easier to just do it directly. And as geriatrician, we have access to the geriatric day hospital, and through that service, the social worker. At Sunnybrook, we have the Sprint social worker that can be accessed. So yes, there is more and more recognition of the need to work in teams. Yeah.
And I think the question was also specifically addressed about the social prescription that we created. So actually, it did depend a little bit on the patient. So sometimes when patients were really, really frail, of course, a lot of time they were actually already followed by a social worker, or we also work closely. Not only did we have a social worker that was accessible through our clinic, but also we had the LIN social worker. But I think for some patients who actually had quite a bit of, high function and no really concerns about, cognitive impairments or mobility challenges, they actually just needed a list of references and, someone to talk to, especially during these difficult months. So I thought that list was also, at least a starting point, and not all of them needed, a full assessment by a social worker, maybe not at that point yet, because the screening test was really just that first capture.
Okay. I'm just going back to Dr. Norris, your presentation earlier, when you're showing the rates of COVID and the different communities and the sectors and the inequalities, I guess, as how I've kind of interpret that in terms of, access and systemic issues that you brought up. So in terms of, the work that we're doing to decrease some of these barriers of access, as social prescribing available, has there been any comparisons to where it's available within the GTA area? And is there any sort of, is there uptake or any reluctance in terms of engaging it with between different communities? Or I don't know if that research has been done. Just curious in terms of, looking at the needs of Black older adults.
So that is so interesting that you would mention that. I think what I'm seeing in the Black community, the community is diverse. And certainly when I'm at Table, when I'm at the Centre Francophone, I see both seniors who are surrounded with family, as that's really the cultural usual way, but we also have Black seniors that came here as refugees or whose children are out of the city and who come to the Centre Francophone or Table without their family. So I think maybe for those people who, sorry, my dog, is to know that there are community centers that cater to Black folks, such as Table, such as Black Creek, such as Centre Francophone. And that could be one way to help link those Black seniors who might be even more isolated.
Thank you. My dog's hearing your dog here. He's going, what's going on?
Hey, my dog is barking because your dog was barking.
Mine are upstairs now, running around. I have the joys of Zoom, right? The last question, I guess, just maybe a comment. I think there's just, there are some areas, I know people are backlogged with COVID, and the wait lists are longer for getting access in a program. So there was a comment there in regards to, some follow-up, but I suspect those are some of the main reasons. I think just, look, just from all your presentations has been wonderful. And I think that's up to all of us to start that conversation. And I think, Dr. Norris, you had mentioned that sometimes, I think all of you, to just having that conversation, starting it, and engaging with the caregiver and with the older adult and the physician about loneliness and about some of the barriers of access to services. Because if we don't starting the conversations or engaging in the discussion, nothing's going to sort of change, right? And I think it's up to all of us as either an older adult or as a care provider or a citizen, to start those conversations with either loved ones. The holidays are coming up, we're being together and having, have you ever thought about this or talk to your physician about it? It's a great time to start these informal discussions, because the issue of loneliness doesn't maybe have the same stigma as some of the other maybe healthcare concerns that older people have. And it may be a good segue into some of those other topics that we're talking about. So I want to thank you both, everybody, I should say, for presenting here today and sharing your experiences. And I will do my best to get the presentation up onto the website by end of today or early tomorrow for people to access. I know there's lots of interest in the session. So again, thank you all, and have a wonderful end of the day. And everybody for joining us. I appreciate your time and support for our continued webinars. So thank you.
Yes, thank you. Thank you. And there was a comment about getting the presentation in French, and probably something that can be tackled in the new year.
Yes. I will follow
Not
up with
looking
that
for
for
more
sure.
work, but since there was a request, thank you.
Excellent. Thank you very much.
All right.
Yeah.
Bye-bye.
Thank